All right, good morning, because it's morning when I'm recording this. I would like to record two substantial videos before we get to our test. Both of these will have test questions, and I just turned off my thing, so here we go again. There we go. First, there's a case study that will really tie things together, especially the last unit that we talked about when we talked about killing cells, natural killers, and cytotoxic T lymphocytes. Both have this some similarities that we can talk about. In fact, this particular case is called X-linked lymphoproliferative syndrome. So you see that it's associated with a sex chromosome, which means that it's probably going to have different presentation in males versus females. And in fact, that's exactly what we see. Lymphoproliferative, you see that you have some kind of lymphocyte is being expanding too much. The thing is that you bring this back to where it comes from. It actually comes from the loss of an activating signal in another cell. And so you have an interesting situation. Remember, the immune system usually has several layers to it. Here you lose an activating signal in a natural killer cell, and you end up with proliferation of B cells because a natural killer cell is not able to kill the B cells it needs to kill. That's why you have proliferation. So just remind you of natural killer cells. This is another textbook's figure of them. I like this one because it shows you an actual stained picture of it among red blood cells. And you can see that they're drawing it kind of accurately. You can see the little granules that it has in it. It has one big nucleus like many lymphocytes. But of course, on its surface, it has very different receptors from lymphocytes. It has natural killer cell receptors like this NKR, that stands for NK receptor. It has KIRs, which will send inhibitory or in some cases activating, but it's shown here as being inhibitory signals when they bind their ligands, which are MHC class 1. And then it has other things like 2B4, which actually look a lot like KIRs, but they're just different receptors. We've given them a different name. They work pretty much the same. You can see here you have an NK cells receiving three signals. Two of them are pluses, one of them is minus. So overall, the NK cell would probably be activated by this particular situation. It's a balance of activation and inactivation. That's what makes immunology so great and so hard to remember sometimes because there's so many things. I want to hold you to the key ideas that there's a balance of signals rather than the name of every single receptor. The important receptors you need to know. There's one other receptor that NK cells have. They have Fc gamma receptors on them. Well, remember, Fc gamma is the IgG constant domain. This means that NK cells have receptors on them that can bind antibody constant domains for IgG. So our question here is, we're seeing a lymphoproliferative syndrome, and one of the precipitating events is infection by a virus in this case study. Viruses mess things up. And remember, that's one of our themes of our last classes, because we had a whole table. We have viruses messing things up. And how do they mess things up? If they mess something up and they become a successful virus as a result, that's a clue that that thing that they messed up is important. So what did they mess up? Of course, they downregulate protein synthesis in general because they want to take over the protein synthesis for themselves. So they make the cell not make its own proteins, and they hijack them for themselves. And in particular, they really don't like MHC proteins because the MHC proteins will carry little bits of virus, and they will activate the T cells that are looking for the MHCs that have something new in them. The best way to deal with that? Keep the MHCs inside the cell. Make them so the MHCs are never made. Viruses will have particular proteins. They don't have many proteins. When they have a protein, you know they need it. It's like they're very light packers. They don't carry much in their suitcases. So if they have a gene that downregulates MHC expression in their suitcase, you better believe they need it. Other things you see in viruses, they have genes that will alter glycosylation or transcription. So the first thing was translation. The second thing is they can alter transcription as well. And if they alter glycosylation in particular, and sometimes if they alter transcription, you'll get new structures on the cell's surface. And there, in fact, are systems in the cell that sometimes will put a new structure on the surface that can then be detected. You can then detect the interior change of viral infection by a surface change. Remember, that's what Wells was looking for with cancer, actually. This is a constant motif of this class. Viruses are inside the cell. How do you detect them? Well, sometimes they make changes inside the cells that accidentally let the surface of the cell change. So, for example, Epstein-Barr virus will infect cells and produce more of surface CD48 on some cells they infect. CD48 binds the activating NK cell receptor 2B4. So this has evolved in the past. NK cell receptor has evolved 2B4 to detect this CD48 molecule, which is a signal of Epstein-Barr virus infection. This is one of the reasons why you have an activating receptor, so the NK cell can kill the viral infected cell. So normal immune systems will have this working right, and they'll clear out EBV infected cells. Now, one of the main things that makes the EBV a problem, when you have a virus that specifically likes to infect immune cells, it can be messing with immunity itself, and that can cause problems. EBV is a virus that infects B cells. And in fact, when it infects them, it wants to make more virus, right? So it actually makes the cells themselves grow. And so it actually, the EBV can actually result in a lymphoma, a cancer type of mutation, a transformation into a cancer cell that can just keep growing because it turns on the growing machinery for the B cell, and then the B cell just doesn't turn it off. It keeps growing. You have a lymphoma. So, and you notice that this is a B cell related effect. So remember that there's a balance of things going on. And the question is, what's going on with NK cells and what's going on with cytotoxic T cells? So if you have a CD8 positive CTL, if its TCR will bind an MHC peptide, that will tend to activate it. If it binds an MHC peptide where it binds the MHC but has never seen the peptide before. But it always needs more than just one thing. You don't take one witness's word on it. You need 2 or 3 witnesses to agree. In fact, if you just have a TCR binding an MHC peptide, and if the CTL hasn't been activated before, if it's naive, then that actually can lead to deactivation. That can be a state called anergy that's shown here. And if you need to pause and read this, go ahead and do that. Co-receptors also need to be engaged. So the co-receptors for T cells, these are cytotoxic T cells. These are like the activating NK receptors. And the MHC peptide is like an NK receptor in that it's an activating signal, but you need more than just one to really have true activation. So some of the T cell co-receptors are CD40 ligand. It's called CD40L. When you see L, you think ligand, and you think it's a ligand for the CD40 receptor. There's CD28 and CD150, which is also called SLAM. These specifically are not that important, but I want you to know that SLAM is actually a receptor that activates a protein inside the cell called SAP. SLAM-associated protein is what SAP stands for. And so SAP is an internal signaling protein that signals that the cell has been activated. This is really important because if you have this internal protein that works to activate T cells, then you also will often see it in NK cells. And it turns out that actually, yes, you can sometimes see it in NK cells. It's particularly connected to this receptor in T cells, but the important thing is that SAP is an activating intracellular protein. So the SLAM molecule, the SLAM receptor that activates SAP inside the cell, on the outside of the cell, SLAM is rapidly induced following their activation, and is stimulated by the binding of identical SLAM molecules on another cell, such as a B cell or a monocyte. And the cytoplasmic portions of 2B4 on NK cells and SLAM, they have similar structures. That's what you should know, because we had 2B4 on this slide right here. 2B4 is important. 2B4 looks a lot like the T cell receptor called SLAM. So I don't necessarily want you to remember all of the CDs, but when you have something like SLAM, I want you to remember it, and it's like the activating NK receptor 2B4. Now, the other thing is I mentioned that NK cells have Fc receptors, and I just want to mention really quickly, there's this one thing that what happens when the NK cell binds its Fc receptor. Well, that means antibody is bound to something else, like what you have here. And so if you have the antibodies all binding to the surface, of course, you can have complement binding to the surface. You can have anything with an Fc receptor can bind to that. And so it means NK cells can actually bind antibody-coated pathogens. And then they can be activated, and then the NK cell can actually destroy the antibody-coated cell. This is a nice combination of antibody immunity with NK. We know that this happens. We don't know how important it is, because there's lots of receptors doing lots of things in the immune system. When it happens, it's called antibody-dependent cell-mediated cytotoxicity. That means a natural killer cell, or I believe in some cases a CTL as well, can have an Fc receptor, binds antibody, and so as a result of when antibody binds, the cell ends up dead. The cell that it binds ends up dead because it brings an NK cell down. Now the thing is, proving this is actually pretty tricky. And so immunologists like to argue about this. And it's actually not a huge point for the rest of this, but it's important for us to get this ADCC is something that you will see. And so this is a category that you need to know about. It's about NK cells binding antibodies. But all of those are different ways that cytotoxic T cells can be activated. If you have a problem in the activation, then you don't have it being activated enough, and then you have part of the body growing too much. Remember that 4-part figure that was question number 1 on test 1? That 4-part figure had a balance of growth and non-growth. But if you have something from outside growing inside you, you have that balance is off, and you have abnormal growth of something outside, therefore you have infection. Virus infection works this way as well. It just means the virus infection means the abnormal growth is from the virus causing your own cells to grow abnormally. And that can be even cancer. So you see these all overlap. So the case study is Nicholas Nickleby. I believe this is a pseudonym because it's a famous name from a Charles Dickens book. But what matters for us is it's the name we're going to use for this case. There's an EBV infection, and you see that there's inefficient killing of the B cells by the cytotoxic lymphocytes and NK cell receptors as well. So here's the case. 5-year-old Nicholas was brought after several days of high fever, no cough, no runny nose, no rash, no diarrhea, no other symptom of infection, just a fever. So physical examination, mildly enlarged lymph nodes in his neck, and they were advised to treat the fever with acetaminophen. But the fever persisted, and he seemed less energetic. Something is wrong. The parents know something's wrong. So he's brought to the doctor several times, and the only thing that they kept finding was that the lymph nodes were large. They weren't even tender. So after 6 weeks of illness, he started to develop abdominal pain. And then that's when you're concerned. You only have one symptom, fever. You can't really admit a child to the hospital over that. Once you start to get the persistent symptom and the abdominal pain, it's time for the hospital. So here's the hospital, and I'm going to read through these. I want you to think about this. I want you, especially those of you who are planning on entering the medical field, this is the kind of thing you'll get. So I want you to think about what these are clues to that points you to a particular organ and maybe even a particular part of the immune system. So he had recurrent middle ear infections. Lots of kids have that. When he was 2 to 3 years old, he had lots of an above level normal of bacterial pneumonia. But they had antibiotics, and those took care of them. At the time, he had low IgG levels. I shouldn't have said that. I should have said 314, but you should compare the 314 to the normal level and see that that's low. IgA and IgM were normal. So family history, his maternal uncle had thrombocytopenia, which means low blood platelets. His maternal grandfather had recurrent lymphomas. And so clues, but nothing conclusive. At the hospital, he was still not symptomatic in any way but having a high fever. His heart rate, his heart sounds, his respiration, his BP, all normal. 25th percentile height and weight, again within the range of normal, but low. And his lower extremities had petechiae, which are skin hemorrhages. There were large lymph nodes in his neck, but not in his other lymph nodes, the supraclavicular, the axillary, or inguinal lymph nodes. His tonsils were moderately enlarged but not red. Again, you have this sort of low-level constant activation. It's sort of chronic rather than acute. His abdomen is distended, tender in the right upper quadrant, and so his liver was enlarged, with a palpable edge 4 centimeters below the right costal margin. So think about that. What blood work would you order? Well, first there's the regular blood work. His hematocrit was 28% when 35 to 40 is normal. His platelet count was 47,000 when 150,000 to 200,000 is normal. And his white blood count was 6,400 when 5,000 to 100,000 or 10,000 is normal. And 22% of those were atypical lymphocytes when only less than 2% of those is normal. So, one of these is normal. So find the normal one, and the other ones are abnormal. See whether they are low or high. Now think about which organ would you test. If you said liver, you're right. Here's the liver tests. Liver can be infected by hepatitis A, B, C, but they didn't find any antibodies to that. The IgM titer against EBV viral capsid was positive, so he's got IgMs against EBV. The titer for IgG was negative, and there were no antibodies detected against the EBV different antigens. He has the viral capsid antigen, but not the nuclear antigen or the early antigen. And so then you have sort of, this is pointing you towards EBV, but a virus, of course, is inside the cell. This actually indicates an advanced sort of chronic EBV infection as opposed to an acute one. Think about why that is true. Also, if you have a chronic EBV infection, you want to look inside the cell. The best way to do that is PCR. That is a DNA copying technique that will amplify particular strands of DNA. So we look for EBV genomes. We use EBV-specific primers, and we run PCR. Again, PCR is something that is brought up should have been brought up in the prerequisites to this class. So what explains this? You don't want to jump to an IgG deficiency. That's not what this is. This is a cellular problem. So I want to caution you against that. But as a doctor, I want you to think, how would you talk the patient through these tests? So the diagnosis is you find out that there's EBV, and then you find out that there's particularly, you can look at the PCR for genes of chronic EBV infection. Especially in boys, you have an X-linked lymphoproliferative syndrome. There's a particular gene on the X chromosome. So girls would have 2 of these. Boys only have 1 copy. So if that 1 copy is messed up, then all their copies are messed up. They don't have a backup copy. That's why this presents in boys who only have 1 X chromosome. And the particular gene encodes SAP. You can look for that with PCR, and you can see that that gene is messed up or not there. So patients without SAP is an activating protein for cytotoxic T cells or NK cells. They can't kill EBV-infected B cells effectively. So they have uncontrolled T cell activation because their T cells are trying to kill these cells. They're activated against the signal, but they're not able to be completely activated because they're missing an activation signal inside the cell. So a clinical study of 161 boys that had XLP, 57% died of fulminant infectious mononucleosis, which is the disease caused by EBV. EBV particularly goes after this signaling pathway, and therefore it shows when you have a problem with your genes. This one particular gene missing tends to go with the EBV because of its infection of B cells. Of the survivors, or well, this is of the total, but of the survivors, about half developed lymphomas, and the other half became agammaglobulinic, which means low in B cells. Think about why these terms make sense if you know the immunology. And in some rare cases, you see the bone marrow itself is destroyed. Again, if you have a problem with your B cells, you're going to be trying to destroy the B cells if they're infected. And that can lead to destroying the B cell progenitors in the bone marrow. This is called aplastic anemia or thrombocytopenia. And if you remember that, we actually mentioned that previously. So there's missing, I want you, if you forgot where we mentioned it, go back and find it, okay? That's the way you learn. So if you're missing SAP inside the NK cell or inside the B cell, so inside the T cell, if you're missing SAP, it leads to a lack of activation. It's the same thing for NK cells. It's just a different receptor, but the same SAP molecule inside the cell. That can frequently happen. So 2B4, you see right here, 2B4 associates with SAP. That is a positive signal that leads to cell killing. If you don't have the SAP, see on the right you don't have the SAP, then what is a positive signal is the absence of a positive signal. Now I have a little bit of an issue with this because they're showing you a negative when what it is the absence of a positive. Those are two different things. And I don't think you should show it as a negative, you should show it as a 0. Either way, you have two positives on the left, and you should only have one positive on the right. Either way, that means less positives, fewer positive signals contributing to the killing trigger, the threshold of signal that will lead to the cell being activated. And if you have less of that, you have fewer activated cells, and more cells survive that should be killed. Okay. So there are defects in both NK and TC activation because it's a missing protein that is involved with receptors on both, the 2B4 on the NK and then the SLAM on the TC. So cytotoxic T lymphocytes are always activated in this case because there's always viruses around. Remember, kids are always infected. So they're not able to clear out the viruses like normal, and that's why you have the chronic activation of the immune system. You have lymphoproliferation, you have cytokine secretion, and macrophages are going to be like, why are the T cells always saying that we should be, why do I have this always low constant? It's like having the TV on all the way. Stresses you out. The macrophages are always seeing these cytokines. They get stressed out. And then when one macrophage just kind of gets overly stressed out, it starts to infiltrate tissue. It's what they do. And particularly they go after B cell containing organs, liver, and bone marrow. That's why you get the bone marrow being attacked. So some histology in these cases, you see something called erythrophagocytosis. That's a word that actually, based on this class, you should be able to take apart. Phagocytosis, obviously. That's what macrophages do. Erythro is erythrocyte, which is red blood cells. You actually can see, red blood cells are small enough that you can actually see a macrophage in some cases that's completely swallowed. It's like a snake swallowing the elephant or whatever. But red blood cells are small and macrophages are big, so this can happen. Really weird, but it's a big sign that the macrophages are too activated. They shouldn't be swallowing red blood cells. They shouldn't be activated like that. EBV infections will activate B cells, and they will contribute to this constant state of low-level immune activation that is it's able to activate the immune system, but it's unable to clear out the virus. The other thing that happens with EBV is because you have activated B cells, they're going to produce complement fixing antibodies. They're producing more antibodies. Some of those will fix complement, and the RBCs bind to complement, and then that causes problems as well. So FAS is upregulated in the liver cells in particular, and remember that liver is an important immune organ, so you'll sometimes see things like this. Probably another result of the runaway cytokines. And if you have more FAS, guess what? FAS ligand binds to that, and then you have cell death in the liver as a result. Overall, you end up with the macrophages starting to kill your own cells, and they starting to break holes in your body. When you have holes in your body, you have hypoperfusion, and that results in shock. Shock is one of the things where your body itself is sort of breaking down, developing little holes in it. They can be developed by macrophages or by other trauma. But this is why you have shock in this case from the immune system, because the macrophages are causing the holes. Toxic shock syndrome is actually similar to this. There's another case study about that. If you're interested, I can copy that for you if you want to know more about that. But it's another case. Toxic shock syndrome is where the immune system makes the little holes, the hypoperfusion that causes shock. So the diagnosis was made, and Nicholas was kept in the hospital. You know that this is a serious problem. Treated with an antiviral called acyclovir. When it ends in vir, it's probably an antiviral drug. And he was given intravenous immunoglobulin. He gave him antibodies to try to control the EBV. But the fever persisted, liver dysfunction worsened. So then the glucocorticoid dexamethasone was added to his therapy, which is what you do when the liver is dysfunctioning and you have the ascites, which I believe is part of the liver. Now I'm getting to my biology where I don't know as much. So these are aggressive interventions. You don't want to do them unless you have to. Despite all the interventions, he developed severe shock syndromes. They resemble sepsis. When you have a persistent infection, sepsis is related to shock. It's the body eating holes in itself. Diffuse vascular leakage, a fall in blood pressure, hypotension, poor circulation, and multi-organ failure. And this made me sad when I read it, so it probably makes you sad as well. All cultures where bacterial pathogens were negative, but this is viral. His body is shutting down. And 10 days later, he died. So it's really, it's a sad ending to the story, but many of these case studies are things that we cannot fix. So at the postmortem, the liver was markedly enlarged. You want to make sure that your diagnosis was right. And so fluid had accumulated in the abdomen and around the lungs. Again, this is related to the shock and the hypoperfusion. EBV was identified by culture and PCR in the liver and bone marrow. And there was a lot of it in the liver, basically. The spleen and lymph nodes had a lot of it. This means that the immune system should have been able to do something about it, but it wasn't. In the liver, they saw extensive necrosis. Examination of bone marrow saw a decreased number of erythroid, megakaryocytic, and myeloid cells, and this is why he had low IgGs. Not because of a direct IgG deficiency, but because the B cells in general were under stress, growing too much, and therefore under attack. So analysis, the real key is you want to do a northern blot, which looks at the gene at the RNA level. And basically the way to read all these is that you have a positive control at the bottom for actin. You want to make sure that you're seeing that the stuff is working. The thing that you're blotting for is working. This is actually an RNA-based technique. We now do this with sequencing. But you see at the bottom, you have a positive result in all three things for actin. The patient is on the right. The patient has no SAP. You have a positive result in a control patient for the middle, normal human that should have a normal gene for SAP. You see how it's weaker, but it's definitely there. And then on the left, you have the Jurkat T cell line, which is a transformed sort of laboratory cell line of T cells that makes a lot of, that basically grows really well and makes a lot of this particular gene. It gives a strong signal. So the JK is a strong laboratory signal of a T cell line that makes a lot of SAP. The control is a normal result, and the patient shows that you don't even have the normal amount of SAP there. So this means the diagnosis was accurate, but sadly there was nothing that could be done about it. There was one bit of hope. His brother, his little brother, could be tested for this, and if they caught it early enough, they could heal it with a very common type of procedure that we've mentioned before. I'm going to be a little bit vague about it because I'm going to give you 4 questions to consider. Think about what exactly in Nicholas's history provided clues before he presented with the fulminant infectious mononucleosis, before he got mono, and again, a lot of people get mono, but what were the clues that you can see? How do you best make this particular diagnosis? Realize that there is a lot of parts to the immune system, and you can't really PCR the liver right away. You can PCR the blood, but maybe it's hanging out in the liver. So PCR is one of the things to think about, but and think about things that are more advanced than PCR. This is kind of an old case study. There are new technologies now. This is how I want you to put it together with other biology classes you've taken. Why would mutations, so there are genes like SLAM and 2B4. What if you had a mutation in SLAM? Why would it also result in the same disease, but it would not be X-linked? What if you had another signaling protein that was in the SAP pathway? That would, and actually SLAM gene is only on CTLs. The 2B4 gene is only on NKs. These are the specific receptors, these in SAP, I want you to think about. If you detect it early, like with Nicholas's little brother, why would a bone marrow transplant be a good option for treatment? They don't tell you if the bone marrow transplant saved Nicholas's brother, but there's a good possibility that if they found a good match and if the transplant took and if it produced good cells, that it actually could fix this problem. Why? Why would replacing the bone marrow specifically address this particular problem? So with all that, sorry for the sad news, but doctors have to deal with good news and sad news. I want you to think about this and think like a doctor. This is the Thinking Like a Doctor video, and I will record the other one later today for you.